I found the greatest creative expression from a career standpoint in not accepting that a system has to work the way that it works. And if you step back and you say, and you allow yourself to dream, what if this worked differently? What would it look like? What would it take? That's always been an entry point for me to go and say, okay, let's have this collaboration with this group and let's change it.
Welcome to the Self-Carapist Podcast. Join me, Lorain Moorehead, a licensed psychotherapist, clinical supervisor, and EMDR consultant, along with expert guests as we explore the approaches and modalities we've used and developed to support our clients' success. Our conversations and stories are designed to inspire new and seasoned clinicians to stay curious, prioritize self-care, and never stop learning. Kevin Curtis is a clinical social worker who has worked in the mental health field for 20 years in clinical and administrative capacities. He is passionate about creating efficient, evidence-based, and human-centered access to mental health care for all in crisis. He is currently the operational administrator for the Huntsman Mental Health Institute Crisis Care Center, which is an 80,000 square foot continuum of care for individuals experiencing mental health crisis. He's also a member of the Center for Health Design's Behavioral and Mental Health Environment Network. This episode talks about the unique partnerships and innovation that have led to developing a visionary approach to crisis care and shows that sometimes there is more openness to solution-focused change than we'd expect if we just dig a little deeper. Kevin Curtis, welcome to the Self-Carapist Podcast.
Thank you for having me.
I'm so excited to chat with you a little bit. So your work now is primarily at the Huntsman Mental Health Crisis Care Center.
Yes, that is correct.
Can you tell me a little bit about what your work entails and about the center itself?
Yes. So I have moved over into that dreaded area of administration. But it's not all a bad thing. My work is really about how can I create systems that have fewer barriers to access? How can I create environments where clinicians can do their best work? Ultimately, I aspire to be Mr. Rogers. I want to be the person that helps the helpers. And so I do a lot of work around really trying to make access to mental health care less barrier-oriented, more accessible, and make the environments in which we provide access to that care better for the clinicians that do that work.
What are some of the ways that you have done that?
Well, so I think, we're social workers, so we know systems tend to do exactly what systems are designed to do, and that's not always what they're explicitly telling the world that they do. So in a typical access center, quote unquote, the first thing that happens in most places is the wallet biopsy, in which we decide whether or not we can actually give access to that person based on circumstances outside of their control, like what is their insurance status, what is their legal status, et cetera, et cetera. So with the Crisis Care Center and the work that I do, a part of how I create better access is by working with stakeholders to create a system that doesn't have to ask those questions. A person truly can walk through the door, be received, and get the care that they need. So that's, I think, one example. And then I think on the clinician side, when you think about an access center, who are the people that are asking these questions, right? They are social workers that have gone into the field because they care and want to help people, and they're immediately made responsible for a process in which they have to decide who can get care based on these things that are not relevant to whether or not they need it. We make care providers the gatekeepers of care if we don't have well-designed systems.
Some of the barriers that you're mentioning are the financial or maybe insurance piece.
Definitely. So oftentimes your insurance dictates whether you seek care, and if you seek it, whether or not you can get it frequently. So why not just design a system in which that doesn't matter, which is an easy thing to say. It's a pretty complicated thing to do in terms of like working in a real world where you have to like pay people salaries and you have to keep the lights on and such, but it's doable. You just have to make that a part of your mission.
Yeah, certainly. I think myself and anybody listening have run into the sort of thing where an insurance company incentivized us to either think of a qualifying diagnosis or not be able to serve the client. I can't even think of a method around that because our system is not used to that. So what sorts of things have you found yourself looking at?
I will say, in the world that I operate, it really is explicitly a world that has to operate in an environment where we are dealing with both commercial systems and federal systems for providing care, right? I think in the general sort of outpatient therapy world, I think that some of these concepts are a little bit harder to work around. So I will say that explicitly. The service that I run is a partially state-funded facility
Mm-hmm.
that's designed specifically to be accessible to people regardless of their ability to pay, right?
Mm-hmm.
So how we accomplished that was we actually started as an entirely governmentally funded facility. We collected a lot of data. We tried to do the best care we could within the context of the limited dollars that you get when you're running public-based facilities. And what we learned in doing that was over 30% of the people we were serving had a commercial insurance product. It just wasn't a part of the model to be able to draw down those commercial dollars. And so in our case, with the way that Medicaid has been evolving over the years, many states have gone away from capitated sort of community mental health center models for managing mental health care of the community, and they've gone more towards fee for service type structures. And in that case, we were able to take the data of fee for service Medicaid based structure, take it back to the commercial insurances and say, hey, we've got better outcomes than the emergency room. We're doing it at a better price point, and we're saving systems cost downstream because we have lower admit rates to inpatient care. Might you want to cover this so that people with your commercial coverage can get this care at a cheaper price point with a better outcome and a better experience? And largely they said, yes, we would like to do that, which is not something you hear from insurance companies so often, right? So I think if I were to one takeaway message about what we did, it was more about systems are kind of set up in a way that you just kind of don't question, is this the way it has to be? And so you just kind of, oh, these are the rules, this is how it happens. And in many cases, stepping back and saying, does it have to be this way? And what are some ways that you might kind of leverage the system to try to make it actually be accountable to what it says that it's doing? And in our case, we were able to get, the Medicaid coverage was there, the commercial coverage came, and then we leveraged a relationship with our state legislature to get a recurring funding allocation to help us provide that care for people that don't have any sort of funding. And with those three things together, we've been able to have this facility operate where wallet biopsy not needed. You come in, you report the crisis, we receive, and we do our best to stabilize and connect to services.
It's exciting to hear about, that you're kind of operating on a new frontier. What are some of the things that you have in place at this facility that allow folks to avoid the emergency room or avoid inpatient? Like, what are some of the things that you're implementing?
Yeah, so I think the easiest way to understand it is, and no disrespect to emergency rooms, they do the best that they can, and they are expected to do so many different things for so many
Mm.
different people. That they are that safety net program that's expected. Everything is expected of them. But in that model, when a person with mental illness goes in, they are really looking at it from a paradigm of what is the symptom, how bad is it, and is it bad enough? Which is not necessarily a bad paradigm, but it's more of like a triage and sorting model. It's not a let's understand what you actually need model. And so what we're doing is really designed more to be about what is the crisis, how bad is it, what are some of the drivers, and are those drivers resolvable? And when you approach it from that way, all of a sudden people that look like they need to be admitted for inpatient care actually see their situation much differently when they walk through the door. So perfect example, within the context of our facility, if a person comes in reporting suicidal ideation and you ask them, okay, is there a driver that we could help resolve? And they say, oh, well, I've had this toothache and I can't get it fixed and I don't know what to do. And it's just like literally, I cannot keep going.
Live with the
Like, well,
pain. Yeah.
what if we got you in to see our dentist tomorrow? Would that help you feel differently about your situation? My goodness, yes, of course it would, right? And so we have an integrated on-site dental clinic in our crisis facility. We have an integrated legal clinic that we're doing in collaboration with the University of Utah College of Law, where when inevitably, okay, well, why do you feel suicidal? Well, there was an eviction notice on my door, or my Social Security application was denied, or any number of these legal kind of connected issues comes up. Well, would it be helpful if we were able to connect you into our law clinic and somebody can talk through with you what your options are and help you find a pathway to resolution? That's really kind of, I think, the crux of our model, understanding why and really kind of looking to address root causes as part of the intervention leads to different outcomes and different experience.
Yeah, it's a pretty amazing thing to hear those two services that someone can be connected with so quickly. Was there research about the dental piece specifically, or was that someone's brainchild?
Yes, and I'm not the expert in it, but what I will tell you is the School of Dentistry at the University of Utah is an incredibly mission-driven organization, and they actually reached out to us when they heard what we were doing. They presented to us data about the link between dental needs and mental health, and when they brought that forward to us, we talked with our crisis workers in the emergency department to say, hey, this is what the dental school is saying. What does this match like the day to day? And they were like, my gosh, yes. You would not believe how frequently unmet dental needs are coming up as a direct driver of mental health crisis. So there's actually an emerging kind of source of lots of data around the connection between dental health and mental health. And as part of this collaboration, one of the nice things about what we're doing is it's happening under this larger umbrella of an academic medical center system. So we actually are providing some of these interventions, and we're engaging with psychiatric and dental researchers to better understand. We know at the anecdotal level the hope that a person feels when they have a connection to a pathway, but we want to understand at the level of population research, what is the impact of this on mental health. So it's a pretty cool partnership.
Yeah, that it's super interesting. I think that one in particular, that connection isn't obvious necessarily. Do your clients have access to primary care in the same way?
Great question. We have built a space to do exactly that. We have not yet made that part of the program operational. It's a program that's currently in development and hopefully to be rolled out in the early part of the next year.
Ooh, you can say I inspired that.
Yeah, yeah, definitely. That is a low mo sort of
Um,
innovation.
yeah. Are there
Sorry, Lorain Moorehead, LCSW. I
That's right.
apologize. Yeah, we know each other in a different context than just the professionals.
Are there any other things that you hope to roll out or any other potential connections that you've seen and hope to add?
Yeah, yeah. So we know both by experience and by data that the period just after coming out of one of these crisis stabilization environments is the period of highest um, potential backsliding, potential risk for people. And so we've recently rolled out a post-discharge follow-up call sort of structure. It's all well and good that you're in this context, you're getting supported, you make a plan, and then you walk out the door. And then you're in the real world where not everything goes to plan, where appointments get canceled, where any number of things that can come and get in the way. And so, having people call and check in on people once they leave. How did that referral we made work out? You know, were you able to make that connection? How can we help support? So that's a very new initiative that we've rolled out, and we are in the planning process of adding in a short-term rolling admissions kind of group support process. So as people are, say maybe we're connecting a person for long-term care with one of the kind of big community mental health providers, it may be 3 weeks before they get in to be seen. So if we're calling them and we're saying, hey, Until you get to that appointment, come in every Wednesday at 5 and we'll have somebody that you can check in with and can help you feel connected. Like we're just really looking at what are the things we can do to resolve the drivers and then how can we own the transitions. Our community is like many others. We have lots of great resources. One of the biggest challenges is people don't know which one of many resources is the right one for them. So we can help navigate. And then also, there's often a disconnect between what you need versus when it's available. So
Hmm.
if we can kind of own that structured support until what you need is available, then we think that we'll be able to make better connections for people.
Yeah, that makes a lot of sense. That sometimes that transitional period is enough to send someone back into those feelings that they came in with initially.
Totally. It is one of those things that I think is pretty perverse when you step back and think about it. Like we are working with very impaired, really challenged, complex mental health issues, and to imagine we can just say, okay, go to this appointment on this day 3 weeks from now, that the person is going to be able to follow through on that without any sort of support. It's hard enough when you're at your best, when you're not worried about jobs or transportation, and you have kind of sound logical thought processes. Um, we have a lot of responsibility in buying into the assumption that people can do this without ongoing support.
Yeah.
A lot of people have failed because we've just assumed they should be able to do that, when in many cases we're setting them up for failure, but by not building in the resource to help them make that happen.
Yeah. Assume they should, or speaking to what you were saying earlier, haven't come up with a creative solution about how to bridge that or even follow up to obtain the information about what the barrier was and getting to that next appointment and tracked it.
Totally. And then the other thing that happens, and I don't know why we do this, but I'm as guilty as the next guy. When they don't show up, we make all sorts of assumptions about why. And we project a lot of like, oh, well, they're just not motivated, or we put a lot of stigma and judgment on the person when it's like, well, did we ask what their transportation scenario was like? We made an appointment for them very far from where they live, and they don't have any sort of transportation. How were they ever going to get there? So we really try to think about these things a little bit more holistically, um, and really try to think through what is the right thing, where's the right place, and what are the supports that are needed for a person to actually make that connection.
Yeah, that makes sense. What is the typical length? Just to get a feel of when somebody comes in, how long are they with you? Is it
Yeah.
hours?
Yes, or longer, or it's really built to be a pretty flexible continuum of care. So within the same building, we have I think that the technical terminology is it's a 23-hour stabilization unit.
Hmm.
It
Yeah.
essentially works like a mental health emergency room. People walk in 24 hours a day, 7 days a week, through the front door with self-reportive crisis, or they're brought in through our law enforcement and first responder diversion channel. If law enforcement are called out to a scene in the community and they see what appears to be a mental health crisis, they're able to bring them directly to us and transition them into a care pathway. And the first step is really evaluation and understanding what the person needs. So in that initial stabilization phase, a person may, need a crisis counseling appointment and maybe starting a medication, and we can do that for a person in, 3 or 4 hours, right? And if that's what they need and they're feeling good and we've got kind of a good follow-up plan, that they're here with us for a couple of hours. But for a person that needs more, they can stay in our stabilization space for up to 23 hours. We use that a lot for people that have lack of diagnostic clarity or they have diagnostic comorbidities. Like the classic example is when a person comes in with symptoms of psychosis and a UA that shows that there are stimulants on board. We like to have a little bit more time both intervening actively, providing antipsychotic medication to see if we can stabilize those symptoms of psychosis while also giving them time to metabolize whatever substances they're on. There's a good chance that at the end of that 23 hours, we'll know whether or not the right move is to send them to a community-based residential program versus admit them for further stabilization of psychosis in an inpatient psychiatry unit. So really the pathways are designed to be flexible. And then within this building, we've got that stabilization and intervention space that's really about receiving the crisis. But then we have our outpatient floor that has kind of intensive outpatient, partial hospitalization, kind of general outpatient type stuff. And then we have an inpatient floor for those that need a little bit more. So we're really trying to almost have this operate like a crisis continuum of care where depending on the need, a person might walk through the door, be with us 4 hours, and be back in the community, going about their life with a feeling of their crisis having been resolved. Or they might go, into our stabilization area to our inpatient unit, and they may be with us for 3 weeks, all told. And it's just really about how do we have all of the different flexible pathways available so that a person coming in can get access to what they need.
So insightful, because often it feels like upon entering a mental health emergency room, the only pathway or the only real offering is to find a bed at an inpatient facility.
Mhm.
And so there's a little bit of gray area in terms of helping the client fit together the pieces that will lead to their stability and putting those in place.
Yeah, yeah, total. It's that whole thing of what's the symptom? How bad is it? Is it bad enough? Right, right. The emergency model is we've got a hammer, everything is a nail. If it's not a nail, we don't have anything for you. And this was really built explicitly to be like everybody that comes in has a specific need, and there's a specific tool that best meets that need. So let's build a broad toolbox. Um, I don't want to be so glowing about what we do that I'm not acknowledging we also can't be everything to everybody. And so with that knowledge, we also understand, and maybe the tool that a person needs is not us. So how do we create collaborations so that we can create a broader definition of us? Um, Maybe in many cases, we're just going to be the one door that the person doesn't have to wonder about, and we help them navigate the 700 doors that sit behind it. So we just really think if you can understand this isn't just a binary, this is a very complex picture where what a person needs is very much tied to their individual psychosocial context. You can't do this work very well if you're not really understanding that that's the reality of what crisis is.
Yeah. Are there any other partnerships that you haven't mentioned that are on your radar to form or that you have formed?
Yeah, so we really think about partnerships pretty broadly. So we've got these sort of care partnerships, but then without going too deep into the weeds, we operate like many people do in complex insurance landscapes. And there are some insurances that don't contract with us for some of our levels of care. So we actually created a business associate agreement with one of our competitors, quote unquote, to be able to have their care navigators come and operate in our space. So when we have a person with that type of insurance come into to care with us, we can absolutely do the crisis stabilization. But if we needed to get an inpatient bed in the old paradigm, we would call their access center and get the runaround because they're prioritizing them and
Their
not
clients that are
us,
in their
right?
facility, yeah.
And through a collaboration like this, you're us, we're you. This person's with us, and it's been an incredible partnership in terms of, um, you know, uh, we know what a person needs, but we may not actually be the right people to access those connections. So if we can kind of bring other people in as partners to that, we can extend our impact and we can get better care. And like our social workers love this partnership because there's nothing they hate more than knowing what a person needs and not being able to get it.
Yeah.
And now it's like, oh hey, so and so, this is what's going on, and that person they just operate kind of is this hybrid between the systems, and they can make these connections happen. So we've done something similar. They're kind of like a big five community mental health agencies that are kind of like the key players in the community mental health space in Salt Lake County. And we have similar business associate agreements with two of those five, and we're in the process of kind of trying to cultivate relationship to build that out with the others. Because what we see is when you can make them an extension of you and you can become an extension of them, that's what removes those silos. Silos protect us, but silos create the gaps that patients fall through.
Hmm.
And in the end, nobody wins because yes, we want to protect ourselves, but I just don't know a person that gets into this field or this work that isn't driven by how do we care for the people that need care. So
Yeah, that is really interesting to think about, that building more partnerships from the back end can actually help a more seamless journey of care for the client. And I just keep coming back to that. The system was developed and we can see how and why. And in some cases, there hasn't been the creative thinking, maybe, and just the tools that were needed to update the systems.
yeah, yeah. I have this metaphor that I think about all the time of that, like, you know, 18th century farmhouse where it was built centuries ago. And then, as times change, it's like, okay, let's put another wing on it. And then, now it's the 20th century, let's do this. And at the end of the day, you have this, you know, grand kind of ramshackle sort of amalgamation of different things, but you also have like stairways that don't go anywhere because do you know what I mean? And so
Yeah.
like I think a big part of why these systems work the way they do is historically we haven't thought about mental health care holistically. We've thought about it's criminal or it's mental health, it's homelessness or it's mental health, it's intellectual disability or it's mental health. And we've got these siloed systems that all operate that are designed to serve something that doesn't exist, which is a person that's only one thing. In reality, um, so many of the people we serve, and this is true across the socioeconomic spectrum, this is not just for, the unhoused mentally ill person that's receiving care from us. It's also true across the socioeconomic spectrum. Frequently, people are mentally ill and they're justice involved, and they, have some gap in their social determinants of health needs. And it's like somebody's got to take on the challenge of like seeing them as something that's kind of more broad than just one thing. So we really lean into that.
I almost wonder if that's the direction healthcare is going to go, because right now there are specialists, there are one person doesn't look at this thing, and just with how big the world is and how small it is at the same time, there are more opportunities to seek the type of care that is needed.
Totally. And I think that's an amazing analogy to think about for anybody that's had a hard to diagnose medical problem. They
Hmm.
know what it is to go to 17 different specialists, and the hopes and the failures of hope and the ups and downs of like trying to really get what you need. And it's largely because there's just not great quarterbacking, or there's not like a great kind of this is the holistic start. Um,
Yeah.
yeah.
I've heard a similar analogy in mental health terms, which is the intake assessment, where directives come down from the powers that be. And so you add and you add and you add a page and you add a line and you add until you have this 30-page assessment that has never been pared down, but you
Uh-huh.
continue to add in the process, creating this barrier to care for the
Yeah,
clinician who's now doing a 2.5 hour assessment, but also the client who has to sit through it and may not have the time or the ability to
totally.
do so.
Or the one we run into that's so like that, like it's not even funny. It's the we'd like to refer this person into care. Okay, complete this intake packet. They're not even a client yet, and I'm writing a novel about them that I don't have the time to write, and it's just so not relevant to what's going on, because guess what's going to happen? Once this person is scheduled, they're going to come in and you're going to ask all of these same questions, right?
Yeah.
And so that's where I think some of these overlapping partnerships. It's like, well, we don't need an intake packet because our admissions worker spends some time there in the morning, kind of meeting with people that are potential new clients, right? It just, um, it really gets some of that bureaucratic nonsense out of the way. Like, anybody that does work on the administrative side, every year they have a new CMS requirement for you have to ask this or you have to do that. So, um, I've also found as a leader of people, the more we add questions, the more we add, the more people start thinking my job is to fill out paperwork.
Mm-hmm.
It's like, no, the paperwork is a tool by which you can understand who the person is and what the needs are. But it's just interesting how quickly we get caught up in the idea that filling the blank is the intervention.
Yeah.
It's not.
Yeah. From a clinical perspective, are there any particular modalities or clinical type interventions that you support your clinicians to use or that you find people using more often than not?
Yeah, we very much want to be a evidence-based care-oriented practice because so many of the clients that we serve come in with suicidal ideation being a part of their crisis. That's been an area where we've put a lot of emphasis on really creating tools and frameworks to support our clinicians doing their best work. So we have a facility-wide implementation of the CAMS framework. Um, what we love about CAMS, and you and I went to school together, so I think you would probably agree with this. I don't remember really having any focused interventional skills around either really assessing suicide risk or treating suicide risk. It's something that I got some exposure to in my practicums, but as I talk with clinicians, it's pretty common for me to hear people just really don't get a lot of structured experience around this. And if they do, it's really more focused around the assessment of risk. It doesn't frame suicidal ideation as a treatable symptom that can be modified and improved, right?
I'll link it in the show notes because I'm actually not familiar with it.
Awesome. No, it's amazing because it really is it's an evidence-based framework. So you actually can do CAMS with a CBT lens, or you can do CAMS with a DBT lens, or whatever your preferred methodology is. CAMS can be helpful, and what it is it's an integrated assessment and intervention where you're looking at the thoughts, you're looking at the drivers of the thoughts, you're looking at means, and all of those things that are part of it. But then there's this additional piece of, are there resolvable drivers that are influencing your thoughts of suicide? And that's tied to kind of number-based ranking systems that then are used to understand a baseline level of ideation and intent. And then through follow-up sessions, they become a measurement of, is this symptom reducing or increasing? So it really is a much more organized and objective way to approach this than just the typical assessment plus safety planning framework that most people are familiar with. And also what I love about it is it almost does a lot of your treatment planning for you, because when you're talking about suicide and what the drivers are for the individual person, frequently they're saying, oh, well, I'm having this relationship issue with my spouse, or I'm having this conflict about employment, or these things that come up as reasons why people come to therapy. And then all of a sudden it's like, oh, by helping a person address some of their relationship issues, I'm actually reducing their suicide risk. As clinicians, I just really don't think that we typically think about it that way, but we've really loved that. So that's been one of our key evidence-based practices. And we're currently evaluating additional kind of care pathway specific interventions that we can implement as kind of like next stage. But we love the idea of, while intervention is art and therapist as artist is something that we all kind of agree with to one extent or another, there are also research has a lot to tell us about approaches that are more effective than others. And so if we can kind of pair frameworks with individual clinician kind of approaches, we like that. We like those sorts of propositions.
Yeah, that sounds great. Um, Similarly, just to put a little bit of a lens on the legal piece, how did that partnership come about? Was that by identifying a need or a common concern that showed up with clients, or was there research specifically around that pairing of legal needs and suicidal ideation?
Yeah, I would say in this case, it was less about we think that it has a meaningful role to play in actual reduction of symptoms and more a reality of we serve a lot of people that we serve without a payment mechanism. And oftentimes payment mechanisms are available to people, and there may be various legal reasons. They've applied for Medicaid and been denied. They've applied for
Oh,
Social Security and been denied. And so we were really like looking at what are systems for putting in place support for people that are eligible for benefits but are not getting them. And we came across research around kind of the more general, they're called medical legal partnerships. We actually haven't found one that's ever been implemented mental health specific. They're more parts of larger hospital systems where hospital systems have found if we invest in making legal support resources available to people, that actually has positive impact on our bottom line and our financial sustainability. Because if they get Medicaid, we can build their Medicaid and we can get payment rather than just writing this off as a charity case. Right.
yeah.
So it's one of those things that was one of the main drivers was we know we serve a lot of people with no funding that actually should have funding, and there's just various different reasons why they don't have it. And so we reached out and had a conversation with the dean of our law school, who just so happened to have experience running a medical legal partnership clinic in kind of one of her past university appointments at a different school. And she was very game to say, okay, let's talk about this. And
Gosh.
it was through that process of dialogue and partnership that we understood, oh, when we think about social determinants of health, almost all of them can or frequently do have a component to kind of some issue of legal related domains. So if a person's stressed out because they're in debt, like debt relief very much has a legal component. If a person's struggling with uh, gender identity and are needing support in getting kind of name changes and kind of legal paperwork around that, that is a legal issue. So many people come in where uh, they have a clear need to be connected to some downstream treatment option, but their legal history is a barrier to them being accepted. So expungement is a major issue.
Interesting.
And so we really kind of looked at it from one angle, and the further we got into it, the more we were like, oh, is this like a 1 + 1 = 5 kind of thing that we've accidentally stumbled upon?
Oh, that's
Yeah,
so cool. It makes so much sense how it started. That hadn't even crossed my mind, but yeah, that legal advocacy piece just to help be the in between. But then also, I feel like restraining orders, needing help with a divorce to be finalized, just there's so many legal
yeah.
considerations.
Guardianship,
Yeah.
for it's just we don't again to the silos, we think about them as kind of clinical issues that are impeding a person's, but they're actually, if you overlay another siloed system, it's like, oh wait, they have expertise to be able to navigate that. So we've really loved delving into that and finding those connection points, and that we can do it in a way where the student component of providing the service
Yeah.
is what allows us to provide access to something that's otherwise financially prohibitive for people to get access to. And we're training the next generation of attorneys in a real world context, right? We're giving them experience about what happens when they're in a non-mental health context and the person coming in for support has untreated mental illness, right? It's just these sort of propositions are incredibly rich when you think about them as clinical access and re- resolution of barriers to forward progress. And we're training the next generation of people in a way that's really grounded in the reality of the world in which we operate. It's a pretty cool thing.
Really, really neat to hear that piece. And in your program, do you have interns also?
We do. Yeah, we have in our facility, we have nursing students, social work,
Mm,
practicum placements, medical students, residents from all over the medical spectrum. We've got learners from just about every background. We
every
also
discipline.
we're heavily invested in the peer support model,
Yeah,
and so we have peer support specialists as a part of just about every program we run in the building, as well as we occasionally host kind of the peer support licensure practicum hours. So we're very invested in um, training creates access and builds workforce. Yeah, it's pretty neat. We've also in that training area. I've always felt there's a pretty big gap between the bachelor's level social service roles and the master's level clinical roles. And as somebody that came out of a bachelor's program with a bachelor's of psychology, it's like, what do you even do with that? So we were able to work with the state around creating a bachelor's level certification. In Utah, it's called Certified Crisis Worker Training, and a person with bachelor's level social service degree or um, kind of experience, kind of equivalent experience to that level, can go through and get this additional certification, and it allows them to kind of operate in almost like a bachelor's plus sort of scenario. They operate under the supervision of licensed clinical social workers, licensed mental health counselors, and what we're finding is that's been like a really good ladder between the bachelor's level into the master's level. So we've had very little difficulty getting our core positions filled, and it's created a real effective way of bringing in less experienced bachelor's level people and giving them kind of incremental clinical experience to where many of them end up completing the master's degree. But there's kind of job growth all along that pathway. So
that sounds really neat. And yeah, so helpful. And I think I even see that with our interns from MSW programs that when they come in, that first internship, you really haven't had much training and education by that point. And so really finding tasks that are exciting and appropriate to the level of education is a challenge. So it feels like that bridge
yeah.
could be helpful.
Or support it in a way that they can gain the skills, right? Like it's interesting, but you can get a first year master's level practicum student that's coming into an environment that primarily does diagnostic work, and they may not have even had their diagnostic
Diagnosis
class,
classes. Yeah,
right?
exactly.
And so in our environment, because we have these sort of I like to think of them as tiered kind of team-based models, that they're able to work really directly with clinicians whose sole goal is to oversee and support the work of people in these kind of supported roles. So they get a lot of just individualized support around, let's build up your skills, let's have you stretch, but let's do it in a way that's supported and overseen by a licensed person with more experience. So it's been a pretty cool training model for sure.
Yeah, it sounds like it. I wanted to dive into the peer support piece a little bit more. So it feels like there's been just an overall encouragement to you to just utilize that level of expertise
Uh-huh.
more. What inspired you, and then what are the best places that you've plugged in peer support?
Yeah, so certainly there's been an increasing body of evidence that there's a meaningful role for certified peer support to play
Mm,
in a person's recovery. Um, uh, there's also in some of the parts of our model, it's increasingly standard best practice to have peer support. So our stabilization service was modeled off of the SAMHSA receiving center model that operates in a lot of communities. We've sort of taken that as the foundation and sort of spun it off into something that we consider maybe an improvement on it. But peer support is very connected to that model of care. And what I've seen, I'm going to risk being a little too reductive here. Um, if you think about patient and patient progress sometimes being a lock that needs to be unlocked, peer support is a specific type of key that can unlock things that nobody else can unlock. There are guests that we serve where I could have a 20-minute conversation. I can incentivize, I can cajole, I can say, just, this medication is going to help you. Please take it. There's a different thing that happens when a person says, hey, I hear they've been suggesting this medication. When I started taking that, this was what I was afraid of, but it turned out to be the very best thing for me. And I'm glad. So if you've got any questions, I'd love to share my experience about that. Or, it's just, um, we in our field, and whether we're talking about the social workers or the psychiatrists or whatever the case may be, we're really prone to this sort of savior complex that somehow we're going to be the thing that solves that problem for them. But ultimately, in most cases, that person making a decision, that person deciding on a change, that person doing something differently, that's actually the thing that creates progress for them. It's not us. And when we're operating our best, we know that, and we just facilitate them doing their work. But peers, I have seen be so effective at being that inspirer of change, that model for change, how change happens, that symbol of hope. The number of times where I've sort of seen an interaction happening between a guest and a peer specialist where there's some version of, wait, a year ago you actually were receiving care here and now you work here? Tell me how that works. And it's like, okay, well, let's talk about that. Let's talk about that. And so we've had people that in their discharge kind of patient experience survey, they're like, this peer specialist was amazing and I can't wait to come back and work here in a year. It's like, well,
Yeah.
there's a whole process and it's a regulated discipline. So we always, if a person while they're under our care expresses interest in that, we take advantage of the opportunity to explain this is how peer support roles work. These are different places within the community where peers do this work. So it does require, at least in the state of Utah, it requires a year of kind of stability and engagement and treatment before you're even eligible to be certified. For a lot of people, like they come in with a sense of my life's over, I'm a failure, and they have this experience of working with a peer where you know something about that. Yeah,
It
I've been
unlocks
there.
hope. Yeah.
I'm you 1 year down the road. All of
Yeah.
a sudden, the process of engagement and healing and hope for healing looks a little bit different. It's pretty magical when you see it operate.
Yeah. It kind of taps into that life worth living piece because you see hope. You see
Yeah.
like yourself on the other side. It seems like substance abuse, that niche has
Mm,
done peer support really well by
yeah.
incorporating people who have that experience um as helpers and by creating those relationships. I'm a big proponent of IOP, especially for adolescents, and I think it's that peer support piece that really stands out to me because I could teach a bit of psychoeducation, but to hear your peers say, "Oh, well, what worked for me was this and that." I can't speak to you, but here's the feedback about what helped me, and that kid, you can just see them tuning in a way that they were not prepared to
Totally.
do to the adult in the room.
Yeah, absolutely.
So neat to hear how it's great to emphasize that it's a regulated position as well and that there are considerations.
Yeah, yeah. I will also be candid. Really leveraging that model and making that a part of what you do, it does require a lot of investment. You mentioned substance use specialty peers. We I work for a large public university, right? And so you can imagine the level of conservative approach into HR hiring processes. Um,
Yeah.
we've struggled frequently to hire particularly specialty type peers, because people that are qualified to be substance use peers often have histories that make them not pass background checks at a very conservative organization, right? So their life experience often coincides with these things that create barriers for them. In the case of the substance use specialty peer, we actually found a way around that by partnering with a community agency called USARA. It's a Utah-based nonprofit that just does substance-oriented peer support, and because they kind of operate and kind of manage those folks, we can have access to them in specific ways through kind of contractual arrangements that allows people access to that specialty care. Sometimes have to make accommodations to support that person being healthy and doing the work that they do. But to me, it's always a thing worth doing. And the benefits of having peer support be a part of your model far outweigh the challenges of operationalizing it in a space. So we love that model.
Yeah, it's neat to hear. I am always trying to make the link between creativity and learning to enhance our experience in this field. I think that, we know there's a lot of burnout, and I think those are two factors that for some people can be very protective. Are there any ideas or any paths to explore that you might have for somebody that's curious about some of the work that you've done here?
I'm gonna share my one of my favorite books, if that's
Please.
okay.
Okay.
4,000 Weeks: Time Management for Mortals.
Ooh,
What I love about this, it's kind of what I would term an anti-self-help book. And what it really reminds us is we have such limited time on this earth. It's sort of depressing for me to say it this way, but like we're all gonna die. And there are so many more things that we could put our energy towards than we actually have energy or time to put towards it. Um, and when I think about life in that way, I just think about every problem that I need to solve differently. I think about every opportunity differently. And I found the greatest creative expression from a career standpoint in not accepting that a system has to work the way that it works. And if you step back and you say, and you allow yourself to dream, what if this worked differently? What would it look like? What would it take? That's always been an entry point for me to go and say, okay, let's have this collaboration with this group and let's change it. Let's kind of make this legislative partnership. Let's find this community agency to help solve this problem because we can't solve it ourselves. We just have such limited time. Why do we want to work in systems that don't do what they're supposed to do? Use your limited time to like actually change that thing, force it to be what it says it is, and let that be your source of kind of creative outlet in the job arena. Why do you want to go every day and just like beat your head against the same wall? Like why? The only thing stopping us from having a different outlook is stepping back and thinking creatively about what could it look like and what would it take to get there.
wow. You went macro as I
I
live
did.
and breathe.
I know my social worker is showing.
You lose touch for a couple of decades and he
Yeah,
goes macro.
yeah, totally. It
I
goes macro.
I love that perspective because it does feel like that. And I think that is the piece that leads to burnout for a lot of people, that it feels like there's one way to do it. The powers that make it so are beyond us. It hasn't been changed. Even you see some dissection now of even the 53 to 60-minute session. And where did that come from? It's not necessarily evidence-based, it's insurance.
Totally.
And so I think that's something really exciting that I think and hope is on the horizon, that there's some exploration of where did some of this stuff come from?
Yeah, yeah. I also I encourage people to like feed their inner kind of stinker pants, that sort of part of you that's resentful about like, you know, well, insurance shouldn't dictate how I provide care or whatever. I think if more of us walked around and looked at constraints as like a challenge accepted as opposed to just a fact, like how much better would the world be if we just were like, no, don't tell me what I can do. Let me bring out my inner rebellious teenager and show you that you can't make me do it that way, or right. And that pushing back against the system was what helps us envision better systems and make better systems that actually do the things that we want them to do. So um, get indignant, push back, resist. You know, there's no better feeling of engagement that comes from solving a problem that somebody tells you that can't be solved. I just think that's something that we can all be a little bit more motivated by.
I think that's a great thought. And it's going to be inspiring. I think it's, in the same way that we were talking about hope, to see someone on the other side, like to see how it's been implemented and just to imagine how it's serving people, I think is a really interesting thing for people to hear.
It's been super fun talking about my work and doing it in this context. So thank you for the opportunity.
Yes, thank you so much for being here. I hope you enjoyed this episode of the Self-Carapist podcast. If you did, please subscribe and feel free to leave a review. You can also follow along at the Self-Carapist on Instagram or head to lorainmoorehead.com/podcast to grab a free copy of your own learning map worksheet to help track all of the tools and strategies you're interested in learning more about. See you next Wednesday.